Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Jill Schaffeld, your host for today. I'm in the studio with Dr. Danny Mallon and Dr. Khalil El-Chammas from the Division of Gastroenterology, Hepatology, and Nutrition at Cincinnati Children's. Today's discussion is on constipation. So welcome to you both. And we'll do just a little introduction to learn a little bit about our guest today. So we'll have Dr. El-Chammas go first. If you could tell us just a little bit about yourself before we get started, maybe how long you've been practicing, how long you've been at Cincinnati Children's, any special interests you might have?
Yeah, thank you for the introduction. I've been at Cincinnati Children's for about 9 years now, and my niche in GI is with neurogastroenterology and motility. And I am the Associate Director of the Neurogastroenterology and Motility Center, as well as the Medical Director of the Multidisciplinary Motility Clinic, where we work with a lot of collaborative physicians, including surgeons and therapists for constipation and other disorders that kids have.
Wow, that's wonderful. Thank you. And Dr. Mallon, any special interests you might have, or you could tell us how long you've also been at Cincinnati Children's? That'd be great.
Sure. Thank you. Thanks for having me. I actually came to Cincinnati Children's just 1 year before Dr. El-Chammas, about 10 years ago. I'm from the area, from Indianapolis, and then trained all over and then came back to the Midwest to practice. And I've been lucky enough to work with local pediatricians working on a lot of quality improvement. One of our first quality improvement initiatives was around constipation in primary care, and we had some successes improving the outpatient management of constipation, reducing referrals, and empowering pediatricians to take care of constipation. So I've really enjoyed that work with area pediatricians developing the tools we're going to talk about today. I also am the director of our celiac disease center here at Cincinnati Children's, but just like Dr. El-Chammas, we all see all comers in pediatric gastroenterology, so we have our fair share of patients who have chronic belly pains as well as constipation and other problems.
Well, thank you both. We're excited to delve into this topic because I don't think there's a day I go by, at least in practice, where I'm not dealing with constipation. So literally, whether it's seeing someone or taking a phone call or giving some advice. So I think this is a very important topic for general pediatricians to talk about. So let's just start by delving into some of the basics of constipation. One thing I think is important to talk about is how we would define true chronic constipation. So just versus an acute episode and chronic, what are kind of, and either one of you are welcome to jump in and take this question, but what would you say really defines a diagnosis of chronic constipation in a child?
Yeah, I think the easiest way to know is if it's been a problem for more than a few months. The research definitions have been, it used to be 2 months to meet our criteria for chronic constipation, especially functional constipation, which I'm sure we'll get into. And they backed that down to 1 month as a criterion, but I think it needs to be present for several weeks for it to become a chronic problem. There's actually really interesting research that suggests that there's plenty of children that will get constipated acutely in a brief period of time. I'm thinking about the kid who goes on vacation and doesn't poop for 4 days, and then they come home and they get back to their regular routine. Maybe a medicine or two can help them get back on track, and they're fine. And the research suggests that 80% of kids will be totally fine treating an acute episode. But we're talking about the kids who are having pooping issues for more than a couple of months.
Yeah, absolutely. And then any data on how many pediatric patients may experience chronic constipation?
Yeah, so I looked this up, and it changes, right, depending on the research
Sure.
study that you look at. There's some data that put it as low as 3% of all children across the world, but there's some data that puts it up to 15%
Wow.
of children at some point in their childhood through parental surveys and school surveys that have experienced constipation for more than a month.
Just curious, as a little follow-up question, you mentioned the change from 2 months to 1 month. Are you able to share, do you know any reasoning behind why that changed? Just interesting to me, but And that's okay if you don't. But.
I wasn't in the meeting. It was.
Okay.
It's actually a meeting of experts around the world, especially Europe and North America, that get together in this something called the Rome Foundation.
Okay.
And they've set those criteria. And while there were friends of ours in the room, we weren't privy to it. But
No,
I think
was
it really
curious.
does. I think I would speculate that the reason was that if you let it go on too long before you start treating it, it becomes harder to treat.
Sure. And then causes true physiologic, problems and anatomical problems with the child itself. So, well, great. I appreciate that. And then I mentioned chronic constipation, but if we even back up a little bit and just generalized constipation, what percentage, and Dr. El-Chammas, you can maybe address this, but what percentage of children would you say throughout their lifetime experience some form of constipation, chronic or acute episodes?
Like Dr. Mallon said, depends on the research and the study and what region of the world that study came from. The numbers are across the board, but on average, I think 30% of patients worldwide have constipation as part of their problem list, their medical problem list. Some of the data suggests that up to 5% of all pediatrician visits are for or related to constipation, which I think you might be able to relate to. And then up to 25% of referrals to pediatric GI are for constipation-related concerns. So it's a big number.
25%. Yeah, that's impressive. Absolutely. Which is why we have such wonderful resources here at Cincinnati Children's, so we appreciate you very much. I did think it was interesting in preparing for this talk that on our community practice support tool that we have that you guys helped develop for the community pediatricians and practitioners, that just data that said that the quality of life rating for kids with chronic constipation is actually similar to those with inflammatory bowel disease and or cancer undergoing treatment. And that's just impressive when we talk about the number of kids that experience this and then how negatively it can impact their everyday life. Just that kind of blew me away and it makes sense, but I think when you realize how impactful it is.
Yeah, I still remember when one of my mentors at Boston Children's, Sam Nurko, put that slide up to teach us that as fellows. And people ask me why I'm a pediatric gastroenterologist, and they're like, "Why are you a poop doctor?" Like, that slide changed my essentially approach to all children with constipation.
Wow.
Because it is absolutely life-changing for these kids to experience constipation. And that was all comers. These aren't just the children who have more severe forms with soiling and things like that. These were all comers. And so knowing that you can make a difference in that very pervasive problem is one of the most satisfying parts of our job.
Yeah, it also affects the families. So the patient, their caregivers or parents, the extended family, their whole life revolves around this patient's constipation and schedule and medication, and it really decreases their morale. So there's a big society burden on this.
Sure.
Parents need to leave work to take care of kids with impactions and clean outs, and it's just not a simple thing to take care of.
And I know you mentioned the motility clinic is multidisciplinary, but is that something you address in the motility clinic, some of the psychological parts of what's going on as well?
Absolutely. When we feel like the family or the patient or both needs some psychological support, we have some psychologists we can make referrals to. Some psychologists are trained to work specifically with patients undergoing constipation or having problems, and that burden on them needs to be addressed, and those specialists are there for that.
Yeah. I think especially as kids get older, right? Just the social impact, school-age children, and just how hard those years are anyway, let alone adding, this chronic medical problem on top of it that's causing pain and, psychological distress. So, absolutely. So how should we as pediatricians or primary care physicians in the office, how should we be like assessing for constipation? Obviously a good history, but are there specific things we should be looking for in that history? Or even you guys can take this question and kind of run with it in terms of, are there specific red flags, maybe things that a parent might say, what the child's saying? Obviously, it's going to be one of the top on our differential for any abdominal pain visit, right? Those are going to be some of the first questions we ask. But, how should we assess what specific questions, what red flags should we look for?
I think I worry that too few questions get asked. That, and I'm guilty of this too, when I'm seeing a patient where constipation is not necessarily the chief complaint. If you're running through almost as a review of systems kind of approach to say, any constipation? Almost as if it's an invitation to, please don't say yes to this question. Or if they say, do they have problems pooping? And you leave it to just one single question, I think there's gaps in that. And I think, I definitely urge people to ask, do they poop every day or not? And inviting the possibility that may not be true. Do they have any painful poops or hard poops? Do they ever clog the toilet? Those sorts of things where they're like, oh, that one time, yes, of course. And you get the funny story out of it. But asking a few more specific questions can actually really kind of change the visit trajectory to really recognize. And I think the other thing is when I find in school-age children, a lot of times parents don't necessarily know their kids' actual pooping habits. I know for my 9 and 11-year-old, I don't necessarily, they're on their own.
Well,
they
thank
go
goodness,
in, they come
right?
out. Yeah, exactly. So they don't necessarily know, and kind of inviting the child to actually answer the question too can be helpful. And asking those specific questions will unearth some truths there. Of course, when you're dealing with abdominal pain, but I think that even at well child checks, we have a very specific lens through which we see these kids who come to our clinics, right? But there's plenty of times where we look at a well child check note that came through, and it was 2 months ago, and it's just a note, and who knows what was actually said in the visit, but it says elimination okay or something like that.
Sure.
And it's probably because nobody brought it up, and the parents didn't know it was a problem, and the kid maybe didn't even know it was a problem until it really kind of causes some secondary effects and things like that.
When it comes to trying to get the answers out of the child and the parents don't know how the poop looks, for example, I think we're talking about tools. One tool I use in my clinic is the Bristol stool chart. Mm-hmm. And I have a laminated copy wherever I go. It's a stool chart that addresses different forms and shapes and consistencies of stools from a scale from 1 to 7. And when we whip that out in clinic, everyone starts laughing and blushing.
Yeah.
And everyone tells us what their number is. Like, I just want the child's. But in all seriousness, this does help us understand when the child can point to or tell us a number. We can understand what the consistency is, and putting that in with the frequency, we have an idea of how severe things are and maybe what medications would be most helpful in the short and long term.
Absolutely. I think the other interesting thing, not just getting the history from a child depending on the age, but I do feel like there are some children who, if that has been their norm for so long, and like you referenced, Dr. Mallon, that, I poop fine. I go every 3 days, or I go once every 5 days, and I'm fine. That's normal for me. Mm-hmm. Or a huge, large caliber stool. That's my norm. Yeah, I'm good, because they don't realize that that's a problem. So getting the history, the parents not knowing the history is definitely challenging, but also just kind of breaking through that your norm might not be what should be normal.
Right, right. And we don't mean to pathologize the kid who poops every other day. No pain, easy to come out, no problems. They're fine. They just don't go every day. We don't need to give those kids medications. That's okay. But it's getting to the details will actually get you the diagnosis when it is a problem.
Definitely. So what red flags on, I guess we can say history and or physical exam should we look for as pediatricians in someone that, let's say, we've uncovered some history of constipation in, or is maybe complaining of some off and on abdominal pain? What specific red flags should we be looking for? And that can be, like I said, in the history or in the exam itself.
Yeah, so especially in the history, I think anything that's a red flag for you for just about any condition, if it's like recurrent fevers, severe pain rather than kind of more mild to moderate pain, if they are not growing well, if their oral intake is reducing, that sort of thing. And then when we hear about blood, of course we can have some blood from anal fissures, from large caliber stools or things like that. But if there's anything about the bleeding that sounds like it's anything but like a perianal source, then that would absolutely get our attention. And then, of course, other more severe symptoms, things like vomiting, things like
Neurosymptoms is another thing that we worry about sometimes. If they have a change in their neurology status, like is their walking different? Is their gait different? Are they toe walking? Back pain, for example. So, like Dr. Mallon said, we look at a lot of systems to make sure there's no red flags that can help us figure out things out sooner.
I'm going to call myself out here. When I saw toe walking on the CPST, I'm like that. I never, when I'm talking about toe walking, immediately think, oh, I should go back and maybe ask some questions about constipation and ask. It's just not something that kind of comes to my head right away. So that's great. And then obviously in infants, lumbosacral abnormalities, things like that, which hopefully would just be all part of the standard well-child screens. So
I think one of the things that I'll call out also is on physical exam, actually doing an external examination of a patient's bottom can be really helpful. The guidelines, international guidelines, and our practice across the board has really de-emphasized the role of a digital rectal exam. If everything fits with functional constipation due to withholding, then we don't need to subject these children who, quite frankly, don't enjoy much happening at their bottom, and so now we could really reinforce that. Nobody really likes it. But the idea that we could actually make that into kind of a negative interaction with us as their healthcare providers and their parents and things like that, we've gotten away from the digital rectal exam in most patients. But the external inspection can be really eye-opening. We all have our own stories of finding inflammatory bowel disease with large inflamed skin tags and fissures that were misidentified as hemorrhoids by a parent or something like that. So when I hear a school-age child with hemorrhoids, that's a huge red flag. And knowing that when there's blood or if there's a lot of pain during defecation, then it's certainly it would be appropriate to do an external examination just to make sure that it looks generally healthy.
And when we do an external examination, we just look at the position of the anus, where it is compared to the back versus the scrotum or vagina, and then the shape, or if there's any asymmetry, for example. At the same time, you can look at that lower back and see if there's any concerns for this, for sacral abnormalities or not.
So one of the things listed also was anal stenosis. And again, other than knowing that they're stooling regularly, so they're passing stool. Well, maybe not regularly, but they're stooling, so they're passing stools, I should say. Anal stenosis, to just see that externally, what should we be looking for?
In severe cases, which is more obvious than non-severe cases, the anus looks really small, like a pinhole, and that is not normal.
Gotcha.
Sometimes, if you're not sure, it could be just the way the folds are in the perianal area. But if a physician takes a look at an anus and is concerned, that concern is probably legitimate, and a consult is warranted. Yeah.
Perfect. Thank you.
It sometimes takes longer for the kids to understand what you're going to do than actually do the external exam visually.
Exactly.
Sure.
And so
Lots of prepping, a lot of explaining.
Right, asking a 7-year-old to, hey, let's take a look at your poop hole, bottom, whatever you want to call it, takes longer. But as long as they understand that you're really not touching, there's no shots or injections, and I usually engage the family to help. So I say, Mom or Dad will touch your bottom, I will stand behind and take a look. That way they can be more comfortable.
Absolutely.
And that way you can get more out of your physical exam. And if the child says no, you have to respect that and just not do it.
Absolutely. That's a great tip. Thank you. Definitely talks we have a lot in our offices as well. So, Before we move on to more management, was there anything else in terms of red flags that we missed or anything that you wanted
Just
to
the
add?
timing of the first poop of life, meconium.
Thank you.
That dark green, black poop, whatever color you attribute it to. I think within the first 24, 40 hours is very important. A lot of times parents forget, but an indirect clue is if they were discharged from the hospital after birth within the normal time period, then likely it happened and it was not flagged by the team and they weren't held on for longer for more workup.
Sure.
But that timing is important to assess for the risk of Hirschsprung's disease.
Yeah, I think it really gets our attention when any infant has infrequent or abnormal pooping under the age of, say, 3 to 6 months. And especially if they don't seem to be able to go on their own without some sort of stimulation of the rectum, the old school thermometer in the bottom or a suppository, that if the greater proportion of their poops are only coming with that rectal stimulation, that definitely is a red flag for us when we're assessing infants with constipation. But then it's tempered by the very common observation that breastfed babies often don't go for several days.
That
and
was going to be
is
my
okay.
follow-up question to
Yeah.
this. We will tell parents 5 days, as long as when they do go, it's nice and soft and it's a good amount and they're eating well and they're not vomiting. So at what point does that changeover happen where we can say, oh, a breastfed infant, this is totally normal for them to have is it a year? Is it, it's a hard question.
It's a hard question. The advice
And maybe
that you
no
just
great
yeah.
answer.
The advice that you just listed off is that when they go, everything looks like it's great. They're getting a substantive amount out. They're eating great. They're gaining weight. There's no vomiting. They're not super bloated. That's all wonderful advice, and it's going to carry you for almost all cases. I remember looking up the average stool frequency at by weeks of age. I think it was an Australian study. I remember being a resident.
There's a
looking
nice
this up.
graph in that article. I think.
Yeah. And things do sort of come, I think I remember by about 2 months of age, 3 months of age, things do sort of get a little bit more frequent in those breastfed infants. You also have a lot more time to observe that child to see how healthy they are. And if they're
Sure.
doing very well and they're still at that kind of other end of the curve of stool frequency, you're generally speaking still fine observing that child and not necessarily, worrying too much.
Perfect. So moving along to management in the office. So one thing I think that I'd like to talk a little bit about, so we can go into just more daily management of chronic versus acute constipation, but also at what point do we look at doing a true clean out? Like when do we cross that, okay, we may just need a help for more short period of time versus, all right, now we've moved into maybe a more chronic picture here and we need to do a clean out, and then how to do that. And this can be for whoever would like to take this question.
So I remember some criteria that were given to me when I was first training in GI after having just done pediatric training as a resident. I was like, oh, that's a little bit more aggressive than I would have done as a resident. And we know that as gastroenterologists, we have a lower threshold to call someone, quote unquote, impacted. And I think that word carries with it some connotations like there's poop stuck. And that's what an impaction is. We're a lot more inclusive about what we call impaction or something that needs a disimpaction or a clean out. And so if you haven't pooped in 4 days, generally speaking, then that would mean that you're going to need something more than just a dose of Neuraxis to get this going, right? And then also soiling and palpable firm stool either in an abdominal exam or a rectal exam should you do one. Just those 3 criteria get me to do a clean out. And so some of that is, you're not looking at poop stuck there and they're not crying out in pain. But the other angle on the definition is it going to take more than a daily dose of Neuraxis to get this better? And if your gut is telling you that, then just go forward with a full clean out.
Sure. And then also probably how long it's been going on, right? Like
Sure.
if we cross that threshold of over a month and we're labeling more chronic constipation, I would say those kids probably are going to need to at least start with a clean out initially and then move on to more of a maintenance.
Yeah, I
regimen.
agree.
And in terms of cleanouts, we can talk specifics about medicines. Give us a little guidance as to what we should expect as primary care physicians, and how to do a cleanout when we use that term cleanout.
Yeah, that's a great question. It's always a good conversation with the family to see what they can do at home and how they can do it with the child. But in my experience, I think doing a clean out just over a few hours or like a one-day true clean out is probably the most helpful in terms of the efficacy and the time constraints from the family. So it would be an appropriate dose of Neuraxis based on the weight in kilograms and dissolved in a certain amount of liquid, Gatorade, or something that the child can take, and doing that over 3 to 4 hours, maybe a little longer if they're having a hard time ingesting all that liquid. Sometimes it might help to get things quote-unquote moving from below with a suppository or an enema, because with all that liquid going in from above, and if that blockage or impaction is not moving, it might cause bloating, it might cause vomiting, and just puts a negative connotation on the whole experience that might affect future cleanouts if they need it.
Sure.
Yeah, when we were looking at the data, when people have evaluated effective cleanouts, the gold standard when newer oral medications like Neuraxis came out was daily enemas for several days in a row, which is a pretty easy thing to want to improve upon. But there are data out of emergency departments, and then there's data out of general or pediatric gastroenterology populations looking at oral cleanouts, and the data would suggest this 1.5 grams per kilogram per day, and they did that for 5 to 7 days, and that was, I think that prolongs things. And so when we developed our protocol with our local pediatricians, kind of putting it all together and putting our own kind of spin and experience on it, if we added in some Senna every day to that, then we thought that we could improve that time down to about 3 days. And so that's how we came up with our 3-day clean-out protocol that's in our community practice support tool and our constipation action plans. But the 1-day clean-out is also very effective, and it's stolen from our colonoscopy clean-out.
Oh, funny.
But oftentimes our
Makes
chronically
sense.
constipated kids, they need a lot more than that to
Sure.
get to a point where they can get a colonoscopy. But this will get them more often than not to get through all of the accumulated stool into the watery stool that tells us that we're done with the clean out.
I think wasn't thinking of it in this sense, but Dr. El-Chammas, when you mentioned the 1-day clean out, just for parents, and when we were talking about social aspects, we can do this over the weekend. We can, hopefully not miss school with this, as opposed to a 3-day, which may be a little bit more difficult to, obtain that. So that, I think, goes into the planning of things as well, and
Yeah.
probably what parents and patients would prefer as
Yeah.
well. So.
Yeah.
And I definitely tailor it to the family. And I think there are kids and families where if you say, I'm going to have you drink 40 ounces of liquid over the next 4 hours, they're going to look at their 3-year-old and be like, what? That's probably an exaggeration of the liquid. But the way I present it to families is, do you want to have it to be fast and done sooner, or do you want it to be slow and gentle? And a lot of times parents of younger children will choose the slow and gentle. The kid who's in diapers, the kid who's at home all day anyways, the kid who, we have a lot more observation period here, and they don't have a dance recital at Saturday,
Sure.
Saturday at 4 p.m., that kind of thing. And I ask them, what's going on this weekend? What do you have going on? Like, this is going to be a time where your child is going to want to be close to a familiar toilet. And so rather than if weekends are your worst day, then maybe it's Friday night that you actually
Sure.
try to get it done, rather than Saturday morning.
Absolutely. And I know we talked a little bit about doing the clean out for impaction. How about just some guidance as to maintenance regimen post clean out, in terms of what should be used, length of therapy, those sorts of things?
Great question. I think it depends on, going back to the stool metrics, like I call it, or their consistency and frequency. it's an issue with having infrequent stools, but they're soft, then maybe a stimulant laxative would be helpful just to get things going more frequently. But if we're talking about hard stools from the get-go, then definitely an osmotic laxative or a stool softener to start off with, plus or minus, other classes of laxatives. What do you think, Dr. Mallon?
Yeah, and that I totally agree. The kind of when we tried to make this fit 80% of kids and we were writing our algorithms, we started with Miralax or polyethylene glycol 3350 because it is the most commonly used. But it is certainly not the only option. There's other medications that are equally effective, actually, in some studies, like lactulose. Milk of magnesia is effective, but we can't keep kids on it very long because of taste frequently. And so that is, there are options to the osmotic laxatives. And then the choice to use a daily stimulant like Senna is absolutely couched in stool frequency. We would empower all sorts of people to use Senna daily for the kid who just needs to have a little bit more habit building around going every day.
Sure.
Their stool infrequency is their main problem, not necessarily stool hardness. And actually, there's some kids where we'll back off the doses of Miralax all the way to like very low amounts or none, and use Senna as their only daily medication, very reasonably and very safely. And we would feel very safe continuing that for months on end. And I think the reassessment every 2 months or so is probably appropriate, because there is definitely some children who are going to get better and they're going to be okay at the earlier time frame. But we all have the experience of the kids who the eureka moment has not happened yet where they're totally okay with letting the stool out when it's supposed to come out. And so they need chronic therapy and frequent discontinuation or just doing it until they're better and then removing it. We all have that experience of kids relapsing back into their old habits of avoiding the toilet and not going when they're supposed to.
Kind of funny question that might feed into what you just said. I hear all the time from parents, well, are they going to get dependent on this? So I would love to hear from the experts, what is your response to that? I know what I typically say, but there's this big almost fear or thought that my child is never going to be able to have a normal bowel movement without using some sort of a laxative. So what is the best response that we can give to parents when we hear that? Because I feel like I hear it all the time.
I honestly tell them not to worry about it. If we need the laxatives to poop regularly and have good consistency and it's making the quality of life better for everyone, it's okay. But like Dr. Mallon was saying, we talk about or introduce the topic of weaning the medication with frequent follow-ups because we don't want them to be on 2 or 3 laxatives if they don't have to. And with time, if they get better, we can start weaning Miralax slowly, hopefully to off, and stick to Senna as a long-term but not permanent laxative. But if it is a permanent issue, then it's totally okay if it's helping them out.
I think we don't have great research, but that not having the research kind of gets us in trouble. It's like, well, then you don't know. But we have plenty of experience, and I actually answer the question from the other direction. I say I have lots of children that I use Senna frequently, and then we're able to get them off of it, and they're pooping normally after a course of treatment. And I can get them off, and that tells me that they're not growing dependent on it, like they're going to need this medication to be able to have healthy poops. Same with Miralax. I also give them the insight that Miralax is not absorbed by the bodies. There's no, quote-unquote receptors that start to get habituated to it. It just adds water to the poop.
Sure. It's not a true stimulant.
Correct.
I think that they do like to hear that, that it is truly just osmotic.
Yeah, and I think the other way I answer the question, which I hope is satisfying, but I don't know if it's satisfying to the parents when I give it this, is if they still need the medicine, it's because they still need the medicine. We don't usually create a need by using the stimulant medication specifically, and certainly not our osmotic laxatives. And so giving that experience of it is absolutely my intention to use as little medicine as possible over time. If they know that that's my goal and not to just set it and forget it and put them on medicine for the rest of their childhood, I hope that gets us on the same page and the same values of we don't want to be medicating children any longer than they need to be.
Well, and maybe that can lead into the discussion of other lifestyle diet changes, water intake, all those things that okay, we're going to be more effective if we all work together here to change some of those other things at home as well. So that's not necessarily my usual response, but in listening to both of you talk, I thought, well, that would be a good lead-in to just some of the healthy habits and lifestyle changes that parents could really focus on as well.
Yeah, I totally talk about medications as crutches and supports that will help us get all the other stuff in place, the habits around appropriate intake of fiber, appropriate intake of water. But more than anything is the daily pooping habits and the kind of internal communication with oneself of recognizing that urge to go and actually turning it into action to going to the toilet and being okay with sitting there long enough to have an effective bowel movement. Those sort of daily routines of making sure that you're moving your bowels every day is absolutely the goal. And the medications help us get there and help us have effective, comfortable, soft, easy poops regularly. And then we take the medicines off, but everything else stays the same. We keep the same routine. We try to have a healthy diet, and we also make sure that we're listening to our bodies and going every day.
One thing that reminded me when Dr. Mallon was talking right now is in the history, you also talk about or ask how the process of sitting on the toilet is for the child. So those physical factors can really determine, is there a problem with the actual evacuation from the way they're sitting or not sitting, and how to also encourage the optimal way to really defecate so to help the patients get off medications sooner than later. So things to ask about, so if they sit on the potty or the big boy toilet at home, and if they're on the toilet, do their feet touch the floor or not for supporting their pelvic floor? How are their knees angle? How is their hips angle? Spending too much time on the toilet reading a book or iPad is not helpful in most situations. So, and then the timing of sitting on the toilet, usually after, we recommend sitting after meals, the big meals, to kind of use our gastrocolic reflex as much as possible. So we give the parents a kind of guide, schedule on when to have the child sit, how to sit, and just help them understand that this may help with the medications to act effectively and maybe get off the medications in the future.
Yeah, that's great. And I don't know that those are things that I ever think to ask, how they're sitting, the more behavioral aspect of things. But it's amazing all of that comes together. At what point should we as physicians, primary physicians, general pediatricians, consider a referral to the gastroenterology department? And then is there any background information that we can provide to you that's very helpful in terms of the initial consultation?
So I think we're happy to see children with chronic constipation. The things that just make me feel warm and fuzzy inside when I get a referral for functional constipation is that the pediatrician has recognized it as such, that they treated it relatively methodically, that they did a clean out if they seemed to meet criteria for it, and that they tried a sustained daily maintenance regimen, and that there was some attempt at counseling about proper pooping, putting in a toilet sitting regimen, that if there was documentation in their notes, or and even better in the referral kind of one-liner, is we did this, this, and this. We did the clean out because it was indicated. We did daily maintenance medications, and I did counseling, and they're still not quite better. Can you please help? I will see that patient all day, every day, with a smile on my face. It's the patients who no medications have been tried, no evidence of any real office visits to discuss it. That's when I really think the pediatrician absolutely would have had just as much success at their first visit as I would have had. But sometimes we hear about a parent calls and into a nurse line, and it's the first time anybody's heard about constipation, and it's bad because it's definitely affecting their lives, and so it's it becomes a referral. We would absolutely recommend doing the constipation action plans, doing what's in the community practice support tool. But if it is not going well, after even just those first attempts, then it's perfectly appropriate to refer that child. Certainly, if there's any red flags for other GI conditions, we would absolutely see that patient quickly. If you have significant concerns about growth or blood or things like that, we would take that physician priority link call and try to see them as quickly as possible if we could. So I think those are the main things. If it's just not going well with the recommended care, and then the red flag symptoms in the history and or physical, of course, we would see them quickly too.
I was going to add that if the physician has tried a few things and they're just not sure where to go, referral, do something else, just give us a call, contact us. We're always happy to talk and, kind of guide the process. Oh, no, this is a referral. We'll see them. Or try this, this, and that, and get back to us. So a conversation kind of helps sometimes.
So Priority Link eConsult is wonderful for that.
Yeah.
And I don't need an answer in 5 minutes, right? But, in the next day or two, that is great. So those are wonderful resources to have. I apologize. I'm going to step back. I just kind of thought about this again. Dr. Mallon, you mentioned other medications besides Miralax, specifically lactulose. For pediatricians, any benefit in one versus the other? When do you choose? Is it Miralax doesn't seem to have been effective, and so we choose, lactulose after that? Is it age? Is it, what would guide you along the lines that you might consider lactulose over Miralax?
Yeah, I think there are several variables that go into that decision, and we all have our kind of own tricks of the trade and opinions about different medications, but a lot of it is what will the kid actually take into their body, right? If a kid refuses Miralax and we're trying every which way to get it into them, then it's okay to transition to something else. One of the positives of lactulose is it's a lower volume of liquid to actually take. It feels much more like taking a medication, usually in a syringe or a medicine cup, rather than facing down a glass of something that they're being told they have to drink within 20 to 30 minutes. I think that's one of the main considerations. Sometimes families come to me with real concerns about Miralax because of maybe misinformation they've seen in the news and things like that. And I will give them as much information as they're willing to take, but I don't let it become an antagonistic conversation, because if I've given them the information that I have for them and that's not satisfactory, which I would say, 75% of the time they're like, oh, thanks for explaining that to me. I feel much better. Let's do it. But if they're still just really wary of the idea, say, fine, we have other medications that work very well, and I try lactulose or something else.
Perfect. Yep. Thank you. And I realized that I wanted to ask that as you were speaking before, so I know I kind of snuck that in there at the end. So we just touched a little on the Constipation Action Plan. Would either one of you like to tell everyone listening now a little bit about, if they're not familiar with what the Constipation Action Plan is? And I believe we'll actually have this linked at the bottom of the podcast as well for anyone who is listening to be able to access it. And then just how important of a tool it can be for general pediatricians and to help us in the office.
Dr. Mallon, this is your tool. You go ahead.
I was going to say, this is a bit of my baby.
Yes.
So this is the best idea that many people have had. There are several places around the country that have actually come up with this, and then they implement it, and then they report on their successes with it, as if it's never been tried before, which is actually a really heartening thing. There have been really great studies out of Nationwide Children's with Catherine Hawa deploying it within a hospital-based system to reduce to improve outcomes in lots of different parameters. This has been tried by Pat Reeves in he's a U.S. Army physician, and he deployed it. He's a big champion of using these action plans for multiple diagnoses. Of course, we stole it from the asthma action plan, and it is modeled exactly after the asthma action plan because it is so useful to identify the patients who need something every day as part of their self-management with a bit of guidance along the way. And it's all written out for them, for the families to refer to. So the Constipation Action Plan looks like an asthma action plan. It's got a green zone, a yellow zone, and a red zone. The green zone is maintenance phase. Everything is going well. But these are the things that we do during the maintenance phase. And it includes daily medications almost all the time. And then it also includes those behavioral things, which, just to demystify it just a little bit further, is it's a daily sitting regimen where they're encouraged to sit on the toilet at a similar time every day, at least once, if not up to 3 times a day after those meals, to try to encourage them to have a bowel movement. It's also eating plenty of fiber, although really pushing the fiber is not necessary. It doesn't have any evidence behind it as monotherapy without anything with it. Hyperhydration is not useful. That's been studied and kind of debunked. But just staying well hydrated, eating a healthy diet with enough fiber. We give a little bit of guidance about how much fiber somebody should be eating. A general rule of thumb is age plus 5, maybe a little bit more, grams of fiber per day. And we ask people to track how often they're going and keep track of how well they're doing with their medication usage. So that's the green zone. Everything's great. When you're in the yellow zone, that's when things are starting to get a little bit difficult. You're skipping days between poops, maybe up to 2 days. You're having a little bit of pain, but not necessarily severe pain, and you need to get back on track. Families know when things are not quite on track, especially if they're using a tracking calendar or something like that. And so this is usually a dose of Senna or a doubling of the Miralax or whatever osmotic laxative they're doing to try to get back on track. And if it seems like they're not on track with daily Miralax, then this is the role where you could make the Senna daily, and that's okay. It may mean that Senna becomes part of your green zone, and that's okay. But a lot of times it's just an extra dose of Senna or an extra dose of Miralax to try to get them to have that bowel movement that's needed to happen over the last 2 days, get them back on track. And then the red zone is essentially a clean out. Things are not going well. There's more significant pain. There's soiling. They haven't pooped in 3 or 4 days or longer. And that's when you say, okay, the yellow zone's not working for a couple of days in a row or something like that. Then you can go onto the red zone and do a clean out and then go immediately back into the green zone. So it's a powerful tool for self-management that you can have the families use and refer to. And I love when families come back to me and they say, we've only needed to use Senna twice in the last 3 months. Or we had to do a clean out 3 times since the last time I saw you. We did increase the daily medications on our own because we just knew that we should. And then we have a great jumping off point to how we can adjust things in the future, because if they're doing clean outs every 3 or 4 weeks because things are not going well, then we have a lot of work to do, and that's okay. But I think it's a really empowering tool, and we would encourage all families or all patients to get one so that they can use it.
Yep, thank you. And I shared before we started the podcast that we use it regularly in our offices. I think it's very user-friendly, and like you said, the families can look and say, I know exactly what I need to do based on where the symptoms are. So that's perfect. I appreciate it. Are there any other useful tools or sites that are worth mentioning? Anything that you guys reference to families? So besides we talked about the Constipation Action Plan and the Community Practice Support Tool.
We're both laughing because we're both thinking about the same things.
Oh, I know this video too.
Yes.
I have it written down here, so I love it. Go ahead.
Go for it.
The Poo and You video.
Mm-hmm.
This was a nurse practitioner at Colorado Children's years ago made this video.
It's amazing.
And it's fantastic. It's timeless, and it's very simple. I actually did a Master's of Education and studied this video as a case study in education.
Oh, that's
and it's
funny.
because it's really high quality patient education
Yeah.
from a video learning standpoint. If anybody wants
And I
to
mean, he's
nerd
on the
out
playground, isn't he? At one
He's
point,
on the playground,
like,
and there's this and it shows this really nice metaphor for a balloon getting stretched up and stretched up and stretched up. It has graphics that are wonderful. It's 5 minutes, so it's actually one of my favorite things to do is while I'm going to get my constipation action plan or something like that, or if I'm going to go get them something, or the nurse is going to print off their after visit summary, we say, let's put on this video for you to watch in the room while we go do this thing. And then we also make sure that they have the link so that they can show family members. Because that's actually a huge thing, is like convincing the other parent or other caregivers, grandparents, aunts, uncles, anybody else who helps care for the child. It's like, oh, it's eye-opening.
Sure.
For
The
the
loose,
understanding.
liquidy, overflowing stools that, no, surely that's not constipation. Yeah, I use, just even in explaining the metaphor about the balloon all the time, just to really try to impress upon parents that, once we do this clean out and they're going regularly, we can't stop treatment because then we go right back to where we were. We haven't allowed time for things to contract back down to normal size. So that and I'm wondering, I can't remember if I saw that video first during residency. I wouldn't be shocked if you in some point might have even told me about it, but I use it all the time, and I love that you can literally just go on YouTube and search the poo and you, and this video is the first thing that comes up.
Absolutely.
So we
And-
could probably link that as well on the bottom
Yeah.
of this podcast.
Our website has really great references, really great resources. And then the American Academy of Pediatrics has a constipation toolkit on their external website for public education. GIkids.org is the patient education website for our North American Society of Pediatric GI, and they are wonderful resources too.
Perfect.
For the older kids, we're having a conversation with the family or the parents about the poop on the daily basis and how to report that is not the greatest. There are some poop tracker apps that I think are usually free, which is great. But that way the patient or the child can, on a daily basis, just using the Bristol stool chart, actually flag the type of stool on that certain day and share it with a parent. So there's no actual talking about this embarrassing topic.
Oh, that's perfect.
But that way that the both can report back to you and your clinic or follow-ups how the numbers are, what kind of consistencies being, or the frequency, so that data can be tracked and can be helpful for everybody.
Sure. That's a great trick for the older kids because
Yeah.
you're right. I'm thinking especially adolescent male. They don't want to talk about any of that to us typically. I'm sure it's discussed everywhere else, but not in front of us. So that is a great tool. Any other little pearls of wisdom you want to share? I know we've covered quite a bit today.
It can be challenging just to help patients and caregivers to get on board with the pathophysiology and the treatment, and just having the patience to go through this with the family is just a lot. And again, we encourage physicians to reach out if they have any questions or concerns. If they're not sure what to do next, just call us and we can help out. We'll be glad to help out.
Thank you.
I think tailoring everything to the patient is very important. Of course, we have our standard algorithms, but those are meant for guidance, and there's absolutely patients who will do better with a little bit of a tweak here and there. One small pearl that I have gained through the years, and actually am teaching our fellows all the time, and any pediatric resident who will listen to me, is we can't treat all children across the entire age spectrum as the same underlying cause of their constipation. Because if you talk to like a 14-year-old young woman about their constipation as if, well, remember that painful stool you had when you were 3 and that's why they don't want to poop, and it just doesn't resonate at all. Because many times it's not a behavioral withholding and an avoidant reaction to the urge to poop because of a history of sort of unpleasant poops when they were young or in the recent past. Sometimes it's pelvic floor dyssynergia, that they actually really want to go and they'll take themselves to the bathroom and they have a lot of frustration around going because of discoordination between the pushing and the relaxing that needs to happen to have a good bowel movement. And so if you keep going, if you have the same paradigm for a 3-year-old as you do for a 15-year-old, then sometimes you'll get it wrong. And so, and there's certainly patients who are still living with the problems they had started at potty training, and then they got into echopresis, and now they have a really kind of broken relationship with actual any pooping habits. And so it can evolve, and there's lots of downstream effects. So just knowing that there's many different ways that somebody can arrive at pooping issues and kind of tailoring your treatment approach toward that. And that's the other time when we would be happy to see those patients in our clinics is if things are not going well with standard treatment, please feel free to send them our way.
Absolutely. Thank you. Well, I appreciate both of you being here today. We've had a little bit of nice thunderstorms in the background for all of our listeners to enjoy. So thank you for being here, and we appreciate your continued assistance for all our community pediatricians and your expertise. So it's been wonderful.
Thanks for having us.
Yeah, thanks for having us.
And for all of our listeners, CME credit is available. There will be 2 questions linked on the bottom of the podcast for you to access.